Whew, got my caffeine level up, so let's talk some oral health. Okay, for those of you who are in this course who are planning on, going into a clinician's role post Lindenwood, whether it's nursing school, PA programs, nurse practitioner, whatever, one of the things that many clinicians overlook is oral health. Um, Last chapter, when we were discussing, you know, septicemia, we were discussing bacteremia, and we discussed that one of the ways that you end up with endocarditis is poor oral health. Here in this chapter, as we're talking the gastrointestinal tract, I told you, first lecture, the first mini lecture for this chapter, the gastrointestinal tract starts at your lips, ends at your anus. So we have to take into account the health of your mouth. The teeth, the gums, okay, these are the structures that the microbes will try to adhere to. Discussed in an earlier mini lecture for this chapter that some of the bacteria will try to stick to the teeth down there along the gum line, maybe even just below the gum line if the gums are starting to recede. One or two bacteria stick via Fimbria. They stick, wait half an hour, 60 minutes. One's now two. Those two in an hour or so will now be four. And they will all either stick to the gum, to the tooth, or will begin sticking to each other. And layers upon layers of next generation daughter cells will start to lay down, and they will start excreting out proteins and polysaccharides, which will start to form this coating. That coating will now be a substrate for other bacteria to start adhering to. And as it gets bigger and bigger, the food we eat, the sugars, the food particles, as we're chewing, will get stuck into that. They call that a biofilm. Okay? The bacteria, by secreting out that matrix that other bacteria stick to, now start to have a minimal means of controlling their environment. The rinsing action of the saliva can't affect them. As that stuff sits there, that biofilm sits there and gets bigger and bigger and thicker, and more stuff sticks to it, starts to become what we call plaque. Dental caries, okay, also what we call tooth decay. I have a cavity, okay, you talk to people about their cavities. That is tooth decay. In a clinical setting, dental setting, they refer to that as a dental carie. What's actually happened here is that the bacteria have secreted digestive enzymes that start breaking down the enamel. While the enamel is not nutritious, the pulp of the tooth below, very much so. Living cells in there, nutrients being delivered by the bloodstream will be there. As these dental caries get deeper and deeper and broader, the tooth itself can die because, as you're sitting there right now, your teeth is living tissue, is living material covered by enamel. The tooth dies, or maybe the gum starts to recede and you get a pocket that the bacteria can get down into. The tooth dies, will come out. Turns out that given time, after that tooth is out, the gum and the jawline, the jaw there, will start to reconfigure. The architecture will slowly be changed. the bone will actually also start to recede away. So we have to be careful on how many teeth you lose. They get pulled. You're not even sure if you get, replacement teeth put in, whether or not they will aid in maintaining the bone. Originally, for the longest time, I don't want to say originally, for the longest time, Streptococcus mutans was the bacteria that they blamed cavities on. Okay? Because whenever they swabbed out the cavities, the dental caries, Streptococcus mutans was always the chief bacteria there. But it wasn't the only bacteria present. Currently, the thought process is it's not one bacteria causing the issue, because remember, you've got hundreds of different species of bacteria and viruses and protozoa in your mouth right now. So it could be that Streptococcus mutans may be the first to the party, but it's the polymicrobial, the many microbes present in the biofilm, that creates the little microenvironment that leads to degradation of the tooth enamel. Turns out we have a greater issue with dental hygiene, specifically dental caries, here in the Western world than in many other parts of the world. I mean, I'm not saying that other parts of the world don't have dental issues. Their dental issues are different than ours here in the West, North America, Western Europe, due to the fact that we have a diet rich in carbohydrates. Heck, I just made the joke, at the beginning of this mini lecture, that I just topped off my caffeine. I had the caffeine in the form of a soda. Turns out all those carbs, not only do they juice me up, but they also juice up the bacteria in my mouth. Now, we want to sit there and think that there's not that big of a deal when it comes to, dental caries. How can they be quote unquote pathogenic? What's the bacteria? So they rot my teeth a little bit. What's the big deal? Well, let's step back and look at what's going on here. It's been shown in a clinical setting. Streptococcus mutans, in the presence of sucrose, starts excreting different carbohydrates that have affinity for each other. They're sticky. They stick to each other. They stick to anything because of the shape and any things that have been added to these long sugar polymers. This is the glue that starts holding all the bacterial cells together, holds the cells together, holds them to the tooth, to get around that rinsing action of your saliva, and allows for the beginning of the biofilm formation. Not only does allowing the plaque to remain on the tooth lead to degradation of the the tooth enamel, but it also will begin leading to a quickened recession of the gum line. The gum will start to recede. The gum actually can become more inflamed. And one of the things that we have found as we've studied the human immune response is that a chronic inflammation in one area will lead to tissue being rearranged, tissues being damaged, or tissues being flat out destroyed. So, as a clinician, somebody's complaining, they're always feeling sick, this thing's going on, that thing's going on. Yeah, look at their mouth. Hey, show me your teeth. Look for that line of yellowish tan plaque down along the gum line. If that's built up a lot, there's a chance that there's going to be other health issues involved. Turns out the bacteria that's going to be involved here, well, horizontal transfer. Food you eat, the food you share, the people you kiss. Turns out, doesn't even have to be a kiss. They have tracked in daycare centers, little kids slobber on everything. They'll slobber on their favorite toy, set it down, somebody else picks it up, sticks it in their mouth. There you go. They just used a mechanical vector to transfer oral bacteria from child A to child B. Best thing to do? Don't let it happen. Good oral health will aid in overall body health. Regular brush and floss. Turns out that the Tinfoil Hat Club, who says that fluoride is an evil thing perpetrated by our government, well, you know what? Turns out the fluoride, the trace amounts in our drinking water, help strengthen enamel. Okay, the enamel strengthened, then it slows down the degradation caused by plaque. Side note, we have been adding fluoride to our water, I believe, since the 70s. The Brits, I don't even know if the Brits even do it now, but the long-standing joke about poor oral health, bad teeth in English people, all that tea they drink, number one, and number two, they don't add fluoride to their water. So no fluoride, lots of tea, low pH, weakens the enamel, and next thing you know, bacteria starts degrading it. Treatment for them is basically to clean out the area. Go in, swish your mouth with some antimicrobial solution, and then drill it out. Drill out the area, pack it in with a filler. Boom. Your cavities taken care of, and then the dentist will go in with probes and whatnot and scrape away the plaque. Go in with a buffer thing and buff it off. Make sure you know that it all gets removed. I mean, when it comes right down to it, by the time you will hit 45, 97 to 100% of you are going to have some form of periodontal disease. Okay? Goes with the water we drink, goes with the diet. You know, it is natural. Okay? What's not natural is, someone your age, 18, 19, 20-ish, 7, 8 cavities, already maybe missing a tooth, gums receding, gums bleeding, things like that. That is a key indicator of poor oral health, which ultimately could lead to endocarditis, could lead to lots of strep throat, could lead to lots of sinus infections, so on and so forth. Gingivitis is an infection of the gingiva, okay? Gingiva is the gums. Okay, if you have gingivitis, your gums are swollen. When you go to brush your teeth and you spit out, there's going to be traces of blood. That is one of the key little signs that you have gingivitis. The other signs you can see there, patches of redness, things like that. In your mind, you could just, disregard that as, oh, hell, I was eating some chips, I may have scraped something, or, things like that. But if there's any bleeding is not normal. Bleeding is bad. Gingivitis can then progress to what is referred to as periodontitis. Periodontitis is when you actually start to see the reforming of the gums. The gums start to recede. There's even more bleeding. It's now not just in one, at one tooth. It could be a stretch of the teeth. The gums are now receding back. The pocket that the tooth sits in starts to get broader, and you start to get bacteria down at the root of the tooth. Bacteria down there, it's a low to no oxygen environment. They will go to town, and you'll actually start to get a bit of an abscess formed. If the abscess is not taken care of, and sometimes you don't even feel a pain really, maybe a slight ache, but no sharp pain, so people will, just disregard the slight ache. Well, that abscess can now start to affect the underlying bone in the jaw, causing the bone to be reabsorbed, the bone structure to be altered. We have to keep in mind that all of this, gingivitis, periodontitis, is not driven by a singular species of bacteria. As I've stated multiple times, you have hundreds of different species of bacteria and viruses and protozoa in your mouth, so it's going to be a mixture of those that are causing the issues. As an example, an old professor of mine was doing research at a dental school, and this would have been back mid-early 90s, and they were studying the grafts that were taken off of periodontitis patients. They were trying to identify what bacteria were there. And while there were numerous bacteria, what they were also finding were amoeba. The amoeba or the bacteria, one or the other, would get into the tissues, cause an inflammatory response, which would begin the recession of the gums, allowing for other microbes to get down under the gum line. So either the bacteria got there first, caused all the issues, and then the amoeba came in afterwards and greatly exacerbated the damage, or the amoeba got in there first, and once the gum line started to recede, the bacteria got in and exacerbated the problem. Treatment, like I said, get in there. The dentist will scrape everything away, the calculus, the plaque. If the periodontitis has progressed to a point where the tissues are now not considered healthy, I mean, we're not talking necrotic, but really swollen, red, just not looking good, they may surgically remove some of it. If you have gingivitis that's going into periodontitis and you go to the dentist, they will use special probes that have lines designated on them so they can measure the depth of the pocket as the gum recedes. So that way they know, they can start to gauge how far along, what level of treatment. If they're showing an abscess, they're showing bacteria down there that could at one point lead to an abscess, antibiotics, antibacterials will definitely be used, along with increased oral hygiene, maybe some special antimicrobial mouthwashes. So it'll be a mixture of treatments, not just here's one thing, one and done.